Hello, and thank you for accepting this clinical vignette to present to the audience at Georgia ACP. This case was put together by myself, Dr. Christopher Chu, PGY1, Dr. Samia Salsine, PGY2, along with our attendings Dr. Malta Shomi and Dr. Kevin Charles of Pulmonary and Critical Care Medicine, and Dr. David Wu of the Prostate Center of Georgia, part of Gainesville Urology Center, who are the attendings overseeing this case. The goals of this presentation is to define what a urinothorax is, differentials of a pleural effusion, and management of pleural effusions. What we are presenting is a case of urinothorax, also known as urothorax. A urothorax is a rare condition where an identified pleural effusion is a result of an accumulation of urine. Now the question arises, how does urine accumulate within the pleural space? Common causes include obstructive pathology such as nephrolithiasis, urinary strictures, or tumors. Other causes include manipulation of the genital urinary tract during urological or surgical interventions. The case we are presenting is a 43-year-old male with a past medical history significant for chronic nephrolithiasis, admitted for right percutaneous nephrolithotripsy in a setting of multiple renal caliculi with hydronephrosis. Stone removal and nephrostomy tube placement was then conducted. Several hours after the procedure, the patient developed right shoulder pain and pleuritic chest pain refractory to IV pain medications. The patient subsequently developed dyspnea and worsening hypoxia. Chest x-ray done at this time showed a large right pleural effusion with compressive atelectasis. Pulmonology service was then consulted for further management. On the second day, CT imaging and repeat chest x-ray imaging was performed, which continued to show a right pleural effusion. A thoracentesis was then performed at this time, and 1.3 liters of serosanguinous fluid was drained. Fluid analysis was then done, revealing a pH of 7.25, protein of 1.1, lactate dehydrogenase of 155, and creatinine of 6.03. The pleural fluid to serum creatinine ratio was 4.75. This was diagnostic for a urothorax. Reaccumulation of the pleural fluid was seen on repeat chest x-ray the following day. A chest tube was then placed with a liter of fluid removed. Empiric antibiotics was then started and discontinued when cultures resulted negative. The nephrostomy tube stopped draining shortly after the chest tube was placed. Several days later, fluid reaccumulation had ceased and a significant symptomatic improvement was achieved. When the pleural creatinine was measured less than 1, the chest tube was then removed. At this time, the patient was then discharged from the hospital for close follow-up with pulmonology. The patient was unable to follow up with pulmonology at scheduled visit due to fears of COVID going on at that time. Less than 70 cases of urinothorax has been reported in the last 40 years. The importance of this case demonstrates the importance of accurate history taking in creating a broad differential regardless if it's a common or rare diagnosis. With pleural effusions, common causes can be related to CHF, infection, or malignancy. This case shows the importance of including rare causes, especially when it can be pertinent given a history such as this when surgical intervention took place. Also demonstrated is the importance of diagnostics as well as tailoring those diagnoses that may not be included in our typical order sets. Diagnostics can confirm a suspicion for cause of the pleural effusion for proper management. This is especially true to identify the etiologies when typical managements including diuresis may not work. Once again, thank you for selecting our case to present to the audience at Georgia ACP.